Hello, everyone. Welcome. Thank you so much for joining this month Fireside Chat in honor of Prostate Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. Move my slides. All right, so this is the Office of Community Outreach and Engagement at the Masonic Cancer Center, and our focus is really to serve as a bridge between the Cancer Center and communities across the state of Minnesota. Our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Engagement Coordinator on our team. And on behalf of our team, thank you all so much for joining us today for an in-depth conversation about prostate cancer. Prostate cancer is the second most common cancer among men in the United States. The American Cancer Society estimates that in 2022, there will be more than 268,000 new cases and about 34,500 deaths from prostate cancer in the United States alone. Prostate cancer often develops without symptoms. Some of the factors that increase a person's risk for developing prostate cancer include age, race and ethnicity, family history, smoking, limited physical activity, and obesity. So today we are joined by University of Minnesota researcher and general urinary medical oncologist, Dr. Emmanual Antonarakis. So Dr. Antonarakis is the Clark Endowed Professor of Medicine and the Director of General Urinary Oncology in the Division of Hematology and Oncology and Medicine, and Director of General Urinary Oncology in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota. He also serves as the Associate Director for Translational Research at the Masonic Cancer Center. Previously, he was Professor of Oncology and Urology at Johns Hopkins Sidney Kimball Comprehensive Cancer Center, the Director of the Prostate Cancer Medical Oncology Research, and the Co-Director for the Prostate Cancer Multidisciplinary Clinic at Johns Hopkins. He is an expert on the clinical management of prostate cancer and other general urinary cancers. He has received numerous awards for his translational research and teaching skills. Dr. Antonarakis' research focuses on drug development and clinical trial design for patients with prostate cancer, as well as cancer genomics. More specifically, he is exploring new androgen-directed therapies, genetically targeted therapies, and immunotherapies for men with recurrent or advanced prostate cancer. He also has an interest in lipid biomarker development. He is the principal investigator of multiple phase 2 and 3 prostate cancer clinical trials. And he is an active member of the Prostate Cancer Clinical Trials Consortium, as well as the National Cancer Institute's Prostate Cancer Task Force and the National Comprehensive Cancer Network's Prostate Cancer Panel. He was recently elected into the American Society for Clinical Investigation. He serves on the editorial board of several oncology journals, including the Journal of Clinical Oncology. He is the author of over 320 peer-reviewed scientific articles, several book chapters, and has edited 2 textbooks on prostate cancer. It is safe to say there is no better person to join the Fireside Chat this month to help us raise awareness about prostate cancer. So we will be recording today's session, so you can refer back to the recording on our YouTube page. It will be posted most likely later this week. Before we begin, I would like our audience to get familiar with using the Q&A feature, which is going to be located on the bottom right of your screen. During today's presentation, please use the Q&A feature to submit any of your questions, and Dr. Antonarakis will have time to answer any of those questions during our Q&A. So without further ado, it is now my pleasure and honor to introduce to you all Dr. Emmanual Antonarakis.
Hello, everyone. Let me share my screen here. And thanks, everyone, for being here. I decided...
Dr. Antonarakis, it's on presenter view.
Okay.
Or speaker view.
Let's try that again.
Perfect.
You never know what screen you're looking at. So thanks very much for the kind introduction. And it did feel a bit chilly this morning getting up and coming into work. So maybe some of you have your fireplaces on at home. I haven't had a chance to light mine yet this year, but I decided not to wear my tie and suit like I had in that picture, since otherwise it wouldn't be a fireside chat. But thanks for the kind introduction. And let me go ahead and talk for about 30 minutes, and then we can leave a good 20 minutes for Q&A at the end as well. So some of you might have a favorite pet or a favorite child or a favorite hobby. I've got a favorite disease, and for me, it's prostate cancer. So let me tell you where the prostate gland is for those that may not be familiar with anatomy. It's this little white round gland here. It's found behind the urinary bladder and in front of the rectum. And it produces a fluid called the seminal fluid. And about 40% of the seminal fluid comes from the prostate gland, and about 60% comes from this other little thing here called the seminal vesicle. And then there's a third little gland here called the bulbourethral gland. So these three things, the bulbourethral gland, the seminal vesicle, and the prostate gland, make the seminal fluid that basically coats and lubricates the ejaculate. What a great conversation to be having after lunch. But it turns out that this little pesky organ can be involved with a lot of diseases. Nobody thought it could be the case. It turns out that the word prostate comes from the ancient Greek word prostatis, and prostatis means the protector. So the ancient Greeks, about 300 BC, coined the term prostate or protector, and they used to think in ancient Greece that the prostate gland protected men against urinary tract infections. They had noticed, and they were correct, that men developed UTIs much less often than women, and their hypothesis at that time, 300 years before Christ, was that this was due to the prostate producing a chemical or a fluid that protected men against urinary tract infections. They were actually wrong, because the reason that men get less UTIs than women is because they have a longer urethra. So it takes a longer distance for those bacteria to travel, from the skin or from the bowel into the bladder. But in those days, they thought the prostate protected against infection. That's why it was called the prostate, the protector. And it turns out that about 80% of American men are going to have prostate disease, not necessarily cancer. The most common disease of the prostate is basically benign enlargement. So the prostate gland is enlarged, and it can cause problems with urinary obstruction, but it's not cancer. But then in a proportion of men, they can develop, cancer as well. The interesting thing about prostate cancer is that most of them are non-lethal. They don't have the ability to spread beyond the prostate gland. And based on autopsy studies that have been done in many, many different places, if you divide a man's age by 2, that gives you the chance of that man having prostate cancer in his prostate gland. So if you're a 40-year-old man, you divide 40 by 2, you've got a 20% chance, if someone was going to do an autopsy on your prostate gland, of finding the cancer. If you're 80 years old, it will be 80 divided by 2, 40%, etc. Now, that seems very, very high, and most people, most men, never have a clinically significant prostate cancer. So although they might have prostate cancer there, it's never detected, and it never causes any symptoms, and it certainly doesn't lead to their death. Now, how many American men get a clinical diagnosis of prostate cancer? It's about 200,000 per year. And of those 200,000, unfortunately, about 30,000 men per year in this country will die of prostate cancer. So it's not the majority, but 30,000 is still a huge number. Now, there's a bunch of paradoxes about prostate cancer. The first paradox is that the other male sex organs, the seminal vesicle and the bulbourethral gland, they basically almost never get affected by cancer. Whereas prostate cancer affects 1 in 8 men approximately. So why is it that the prostate gland, which is fueled by testosterone, is prone to cancer, but the seminal vesicle, which is also fueled by testosterone, almost never gets cancer, and the bulbourethral gland, there has actually never been a case reported. And one of the theories is that the prostate gland has a lot of inflammation. Prostate gland can get inflamed, and some people believe that it's the inflammation that can increase the risk of cancer, prostate cancer. But another paradox is that while normal non-cancerous prostate tissue is often very inflamed, so in the left picture here, these bright yellow or orange fluorescent stains are the immune cells. So there's a lot of immune cells here in the prostate gland. This is a benign, non-cancerous prostate gland. In prostate cancer, which is shown on the right, you're not seeing any of these brightly colored cells. In other words, the immune cells are not really getting into the cancer. So that's paradox number 2. Even though inflammation, which basically means activation of immune cells, is very prevalent in benign prostate tissue and increases the risk of prostate cancer, the cancer itself doesn't really have any inflammation within itself. So that's something that people really have struggled to understand. The other strange thing and unusual thing about prostate cancer is that it's multifocal. Multifocal means there usually isn't just one spot within the prostate gland that is affected. This is a prostate gland from a patient that has undergone a prostate surgery, a so-called prostatectomy. And each of these arrows on the right-hand side, which kind of look like these pale yellow circles here, are different focuses of prostate cancer that are not attached to each other. So all 4 of these different prostate cancers arose, independently and are not part of the same thing, but they're all within the same prostate gland. And here, the pathologist has circled at least 3 or 4 or 5 different areas that are not, touching each other. And so this is a disease that, if it occurs, it isn't usually a one-off. The men that are predisposed to prostate cancer often have multiple spots within the prostate gland. So we call that a multifocal cancer. And of course, prostate cancer is not only relevant in the United States. Virtually every country in the world has prostate cancer incidence. So about 1.3 million cases globally per year. But interestingly, and this might seem like a paradox, again, another paradox, prostate cancer incidence is higher in the developed world and much, much lower in the underdeveloped or developing world. So the curves on the left show the incidence of prostate cancer in European countries from 1975 on the left all the way to 2010. The blue curve here is France. So France, which is one of the most developed European nations, has the highest incidence, followed by Finland. And then a country like Slovakia, which is sort of more developing, although it's still within Europe, has a much lower prevalence. And then in East Asia, and also Africa, which is not shown here, the prevalence is actually far, far lower. So higher socioeconomic status and higher wealth within a country, rather than decreasing the prevalence, actually increases the prevalence. And this leads us to hypothesize that it's perhaps factors such as diet, especially diet that is affordable by affluent societies, that may perhaps be one of the factors that increases prostate cancer risk. So in the US, about 1 in 8 men will be diagnosed with prostate cancer. That is relatively high. It's obviously the most common male cancer. So what are the risk factors? Age is by far the highest risk factor. Prostate cancer is extremely rare in your 40s, increases with age, and by 70s or 80s, prevalence is higher. We also know that African Americans have the highest risk And there have been interesting studies looking at genetic ancestry, and even within the African continent, there's a high prevalence of prostate cancer in West Africa compared to other locations. So it's not just enough to say African American. There might be particular regions or countries within Africa that have even higher rates. And again, as I mentioned before, it seems to be lowest in East Asian countries. There are some genes that can increase the risk of prostate cancer. So there's definitely a genetic component. As Amna mentioned at the beginning during her introduction, weight gain or obesity, as well as Western or affluent diet, especially diets that are high in animal fats, diets that are high in cholesterol or sugars, increase the risk. There seems to be some controversy, although some believe that a less active lifestyle with less exercise can increase the risk. But again, interestingly and paradoxically, even though testosterone level fuels prostate cancer once it develops, high testosterone in someone who does not yet have prostate cancer does not appear to be a risk for getting prostate cancer. So a man who has high testosterone level to begin with, who doesn't have prostate cancer, he probably isn't at higher risk of prostate cancer. But if he gets prostate cancer and he happens to have a high testosterone level, then that can make his cancer grow faster. So lots of paradoxes, building up with prostate cancer here. Let's talk a little bit about African Americans. They are at higher risk of developing prostate cancer. They're also at higher risk of developing cancer at an earlier age. So usually African Americans or Africans develop a prostate cancer 5 to 10 years earlier than Caucasians or European Americans. Also, when they're diagnosed, they tend to be diagnosed with higher stage and higher grade cancer. And furthermore, once they get prostate cancer, they are twice as likely to die from lethal prostate cancer compared to white or European men. And there have been various theories about why this might be the case, including socioeconomic status, access to care, limitations, clearly some genetic factors that don't tell the whole story, of course, and perhaps some different dietary factors. Now, if you look at the top most prevalent cancers in the US here, you can see that prostate cancer is third on the list. If you exclude breast cancer, which really primarily occurs in females, in men, prostate cancer is the second highest, after lung cancer. And as was mentioned before, about 200,000 cases per year in the US. That means new diagnoses, and then 33,000 deaths. But if you add up all the men who have a previous diagnosis of prostate cancer, not just the new diagnoses, you get a prevalence of about 3.2 million men. So this was based on 2020. So at this point in time, or at any given point in time in the US, there are approximately 3 million men living in the US with some stage of prostate cancer. And just to put that in perspective, the US population is about 330 million. So 3.2 million is 1% of all Americans. So 1% of all Americans right now have prostate cancer. So it's a big problem. And this shows differences by race and ethnicity, showing that white or European American ancestry patients have a lower incidence compared to Black. Asian or Pacific Islanders living in the US have a lower incidence. And then Hispanics have an incidence that is in between, a little bit higher than the East Asians, but lower than the African American or Black. And these same trends are mimicked when you look at death rates from prostate cancer, where the highest death rates are in Blacks or African ancestry individuals. The lowest death rates are from East Asian Americans, etc. This shows how the incidence of prostate cancer increases by age. So in men between the age of 35 to 44, it's basically unheard of, only 0.4% of the time. By the time you get to the 45 to 55, it's about 8%. By the time you get to 55 to 64%, it's 32%. And then it peaks. So the age at which the majority of men in this country are diagnosed is between age 65 and 74. And then again, it drops off after that. So the highest risk decade for a man to develop prostate cancer is 65 to 75. It's not to say that they can't get it if they're older, but they've passed like the most high risk age. And then unfortunately, with respect to death, the chance of dying of prostate cancer increases with age. And part of the reason for that is that the risk of death overall, of course, also increases with age, irrespective of cancer. So very, very few deaths from prostate cancer in 40s or 50s. But once you start getting into the 60s and 70s, the chance of getting a prostate cancer that you will die from is higher. Now, that might be a little bit of a bummer, so let's focus on some good news. So the good news is that the deaths from prostate cancer peaked around 1991 to 1992, and since then have begun to decline. Why is that? Well, the PSA test was developed in 1987. Between about 1987 and 1992, PSA uptake was beginning to increase in this country. And by 1992, we reached our peak of awareness of PSA screening. And after PSA screening became widespread, the death rate from prostate cancer began to decrease. Now here, between 2010 and 2020, you can see a flattening of the death rate. And part of the reason for that is because some of the guidelines have started to recommend against PSA screening. That seems crazy to some of us. We'll talk about that a little bit later and why that happened. But suffice it to say that screening is a little bit more controversial now than it was in the early 1990s. I don't think it should be controversial, but many other people do think it's controversial. And on the other hand, the survival rate for prostate cancer has gone up. It went close to 100%. It has dropped off a little bit in the last 2 or 3 years. And unfortunately, that's also because of the decreased uptake of screening in the last few years. So why is prostate cancer unique? It's the slowest growing of all cancers. It doesn't mean that it's not a serious cancer. A lot of patients get really upset if you tell them, this is not an aggressive cancer, because it is still cancer. It is highly curable if it's discovered early and if it has not spread to other organs. So if the cancer is contained within the prostate gland, it can be readily cured. Even in patients where it is not cured, the lifespan can often be very, very long, 10 to 15 years, for example. And then we have a number of biomarkers that we can use to either track the presence of prostate cancer, or even in some cases to use the biomarker as a treatment for prostate cancer. We'll talk about PSA and PSMA momentarily. And the main way that we treat prostate cancer that has come back or has spread to another organ is by blocking testosterone, which is the male sex hormone that feeds and fuels prostate cancer. And these are so-called hormone deprivation therapies, also called androgen deprivation therapies. And when we deprive a man of testosterone, we can starve his cancer to death. And that success rate is greater than 95%. So that is good news. The bad news is if prostate cancer has metastasized, meaning if it has spread to other organs, it's typically not considered to be curable, although as we mentioned above, the lifespan in those patients can still be as much as 10 to 15 years. And then a unique thing about prostate cancer is that when it spreads, it likes to spread to the bones. There are certain cancers that like to spread to the liver or the lungs or the brain. Prostate cancer can spread anywhere, but in general, it usually spreads to the bones, and that's the place that it might go to first. And a lot of the symptoms from prostate cancer could be due to these spots in the bones. So when a man is first diagnosed with prostate cancer, what type of symptoms might they experience? This is a list here with some cartoons, they might experience frequent urination or a weak stream, or sometimes blood in the urine or in their ejaculate, or sometimes they have to strain to pee, or sometimes they have burning on urination, urgency or waking up at night to urinate, or of course, impotence or erectile dysfunction. But the truth is, even if you look at this whole entire list, the majority of men that are diagnosed with prostate cancer actually don't have any of these symptoms. And the only way that they know that they have cancer is by doing the PSA test, which is why I believe screening is so important. Now let's talk about PSA screening. It used to not be controversial. Ever since around 1992, it was always recommended for men, over the age of 50. But then around 2012, there was a very harmful thing that happened. And the harmful thing that happened was the organization that comes up with screening guidelines for the United States, which is called the U.S. Preventative Service Task Force, in 2012, made a decision to give screening a grade D recommendation at that time. Grade D means they recommended against it, not just that it was neutral, but actually recommended against it. And the person that was chairing the U.S. Preventive Task Force at the time happened to be a pediatrician, and I'm not even joking. And of course, kids don't get prostate cancer. So this decision was made by a doctor that doesn't treat prostate cancer. And that individual's decision unilaterally affected the prevalence of prostate cancer between 2012 and 2017, where the prevalence began to go up again. And then in 2017, when they looked at the incidence of prostate cancer in the United States, they said, oh crap, we made a mistake. People are getting diagnosed at a higher rate than they were in 2012. Maybe we should go back. Instead of saying, let's recommend against PSA screening, let's say we're going to go back to a grade C recommendation. And grade C basically means discuss the pros and cons with your doctor and participate in a shared decision making. Okay. Now, I'm glad to say that as of 2017, screening is now recommended a little bit more strongly again. There's also the American Urological Association, AUA, and they have always, and they still do, recommend screening for people over the age of 55. They do not recommend it for anyone under the age of 55 because the prevalence of prostate cancer below 55 is so low. And then the American Cancer Society, ACS, also says that it should be recommended after a shared decision-making between the patient and their doctor. So we're making some progress, but the grade D recommendation of 2012 was very, very hurtful to all of our patients, and especially to those who were at high risk, like African Americans. And we saw, as I mentioned before, a spike in the incidence of prostate cancer between 2012 and 2017. So what on earth is PSA? It stands for prostate-specific antigen. It is actually a protein that is made by the prostate gland, and it's a protein that is secreted from the prostate gland into the bloodstream. It can be made by the benign prostate gland, the non-cancerous prostate gland. It can also be made by prostate cancer, but it's not made by any other tissue or organ in the body, so it truly is prostate-specific. Interestingly, the function of the PSA is not really known. Some people think that it helps with fertility, but the jury is out. And PSA can be raised not only by cancer, it can also be raised by infection or inflammation of the prostate called prostatitis. And actually, it can also be raised by just benign prostatic hypertrophy, in other words, enlargement of the prostate gland. Now, let's talk about what we should be recommending right now in 2022 for PSA screening. So in my practice, I recommend a PSA screening for all men over the age of 50. And of course, it's a decision that has to be made after shared decision-making. So it's not like a top-down decision that the physician makes on his patient's behalf, but at least it should be discussed. And then here in the middle, I've written some other more minute details here. How do we do PSA screening? There's two ways. One is we check for the PSA in the blood, but the second is the famous rectal exam, also called digital rectal exam, DRE. And I have to say, most men, hate the rectal exam. It is important to do both approximately once every 1 to 2 years. There are some prostate cancers that can only be picked up on the rectal exam with a normal PSA. And then there are other prostate cancers that are picked up with a high PSA, but a normal rectal exam. And of course, there are cases where both the PSA and the rectal exam are abnormal. So if you want to cover both bases, it really is important to do both, not just one or the other. And a lot of men, they're happy to do the blood test, but they want to skip on the rectal exam. It's really not recommended for anyone over the age of 75. Again, given that the life expectancy of prostate cancer is 10 to 15 years, if you're above the age of 75 with appropriate treatment, you would not benefit from screening because the treatment is good enough for that. And then finally, anyone who has other serious medical illnesses where their life expectancy is less than 10 years, that individual also probably does not need screening. And then there's a group of patients that are at particularly high risk who should be screened at a younger age, younger than 50, perhaps even starting at age 40. And those would be patients that have a family history of prostate cancer or breast cancer, those who are African Americans, especially African Americans with a family history of prostate cancer, and then anyone who comes from a family with a known genetic mutation, such as the BRCA2 gene. All those patients should consider screening for prostate cancer starting at age 40. And again, that would be with both a PSA test every 1 to 2 years and the digital rectal exam 1 to 2 years. Now, I'll just put this out there for anyone who is a patient or a patient advocate who's on the call. You don't need to answer this question, but just think about the question in your own head. So for those of you who are men on the call, how many of you who are above the age of 50 have never had a PSA screening? How many of you have discussed it with your doctor but decided against it? How many of you have discussed it with your doctor and have done it? And then how many of you have had an abnormal PSA test and have had a biopsy to exclude or confirm the diagnosis? So think about that. And if you are one of those people who is above the age of 50 who has not yet done that or discussed it with their doctor, hopefully this will be a motivation for you to do so. Now, one of the reasons that people don't like to do PSA screening is because they don't want to think about the prostate biopsy. So how is a prostate biopsy done? Unfortunately, it's not the world's most comfortable procedure. It's done through an ultrasound scan that goes into the rectum. It's called a transrectal biopsy. These are done by urologists. So you get referred to the urologist. The urologist does an ultrasound through the rectum, and then while he is looking at the prostate gland through the rectum, he is taking a biopsy needle and taking around 6 biopsies from the left-hand side of the prostate gland and 6 biopsies from the right-hand side. Typically, 12 biopsies are done at the same time. And for those of you who have had a prostate biopsy, I'm sure that all of you would agree it's not a procedure that would be considered fun, and it's not a procedure that most people would want to do twice, although some people have had to do it twice. And unfortunately, that is the most direct way to get access to the prostate gland, because if you try to go from the front, it's quite deep inside the pelvis and it sits behind the pelvic bone. So it's much easier to access the prostate gland from the back, from the rectum. And if you get a biopsy, this is what the pathologist will be looking at under the microscope. And we score prostate cancer by a scoring system, which is called the Gleason score. When I used to be at Johns Hopkins, I would remind everybody that the Gleason score was named after Donald Gleason, who was a pathologist in Minneapolis, Minnesota. So now that I am in Minneapolis, Minnesota, I have to remind people that Dr. Gleason worked here in Minneapolis. And he came up with this classification in 1963. And this diagram here is actually a hand-drawn diagram from Dr. Gleason's diaries. And the lower the Gleason score, the less aggressive the cancer. And the higher the Gleason score, the more aggressive the cancer. The Gleason score is a score that goes all the way from 6 out of 10 all the way up to 10 out of 10. And 6 out of 10 is the lowest, which means the best prognosis. And 10 out of 10 is the highest or worst prognosis. And the Gleason score is now summarized into 3 categories: a so-called low Gleason score, which is Gleason 6, and intermediate Gleason score, which is 7 out of 10, and then a high Gleason score, which is 8, 9, or 10 out of 10. And if you've ever talked to your medical oncologist or urologist, he will always, or she will mention the Gleason score as a way of predicting the prognosis for that patient. Now, there's some controversy about Gleason score 6. Should this be called cancer or should this not be called cancer? It turns out that fortunately, Gleason score 6 in general is a very dumb cancer. By dumb cancer, I mean that the cancer is not smart enough to be able to metastasize, to spread to other areas. So if you've got to have a cancer, you might as well have a dumb cancer, not a smart cancer. And Gleason 6 is as dumb as it can get, and it typically remains inside the prostate gland, isn't capable of penetrating through the prostate capsule, and typically, with rare exceptions, is not capable of producing metastases. And in most databases, there have been very, very few deaths ever documented from a patient with Gleason 6. They typically die with prostate cancer, not of prostate cancer. There was a controversy a few years ago about renaming Gleason 6 and changing the term to something like a precancer. But technically it is a cancer, so the name has not changed, but it is a cancer that is highly, highly curable. Now, one thing to remember is that not all prostate cancers even need treatment at all. Some of them can just be watched very carefully. And we call this active surveillance. It used to be called watchful waiting, but now the term active surveillance has replaced the term watchful waiting. We typically only recommend this for men with the Gleason 6 score, and we sometimes also recommend active surveillance with a Gleason 7 if the patient has major other health problems that might limit his lifespan. But really, when the Gleason score goes above 8 or 9 or 10, typically we do not recommend active surveillance for those patients. And again, the reason that we recommend surveillance is because all treatment has side effects, including surgery and radiation. And the 2 most common side effects of surgery or radiation are urinary incontinence, in other words, leakage of urine, or sexual dysfunction, erectile dysfunction. Now, this used to be a slide that I would show, back when I was at Johns Hopkins. The radical prostatectomy was invented at Johns Hopkins by Dr. Hugh Young. The first radical prostatectomy was done in 1904. So we have passed our 100-year anniversary of the first prostatectomy. But truly, the modern day radical prostatectomy was invented by Dr. Patrick Walsh, who is still alive and practicing. He is in his 80s now. And in 1983, Dr. Walsh invented the nerve-sparing retropubic radical prostatectomy. And this diagram was a hand-drawn diagram that he published himself in 1983. And basically, this was the first time that we recognized that the nerves that are responsible for erections have to be dissected out, and they have to be preserved. In other words, they have to be very, very carefully protected and not cut through, not sacrificed during the surgery. And by preserving and not sacrificing the nerves, oftentimes there is some sexual function remaining. It's not perfect. It's not as good as it is before the operation. But prior to 1983, all men that underwent the prostate surgery were basically impotent for life, and that is no longer the case. The other way to treat prostate cancer is to radiate the prostate gland. There are 2 main ways to do this. either with the so-called external beam radiotherapy, where invisible X-rays are passing through the body and targeting the prostate gland and the seminal vesicles. This is typically a 7-week treatment where patients come to the radiation oncology clinic 10 minutes per day, 5 days per week over the course of 7 weeks. Or the second way is called brachytherapy, or brachy for short, or sometimes it's called seeds or radioactive seeds. And these are these tiny radioactive seeds that are inserted on a single day, usually under general anesthetic. And again, this is done using a transrectal ultrasound, and it's done while the patient is in the operating room. And these seeds are then placed into the prostate and they are radioactive. So this prevents the patient from having to go for 7 consecutive weeks to the radiation oncology clinic. The brachytherapy or the seed therapy works best in patients that have lower Gleason scores. So for those patients that have high Gleason scores, let's say Gleason score 8, 9, or 10, the amount of radiation that can be delivered through these seeds is typically not enough to kill all the cancer. So typically the seeds are for the Gleason 7 or the Gleason 6 patients. And again, focusing on the good news, if prostate cancer is detected early, and if the patient is fit for either surgery, which is called prostatectomy, or radiation therapy, there is a 60 to 80% cure rate. So more than 3/4 of these patients will likely be cured. Now, unfortunately, not all patients are cured, and between 20 and 40% will relapse. And here on the box on the left, where it says clinically localized disease, those are the patients that are typically cured. And those patients are often managed by the urologist or the radiation oncologist. Usually they won't even see a medical oncologist at that point in time. But then if the PSA level recurs or comes back after surgery or after radiation, that's typically the first sign that either some cancer has been left behind or that the cancer has recurred after an initial remission. And that's typically when these patients will see someone like me, a medical oncologist. And unfortunately, some of those patients may progress to develop metastatic prostate cancer, going through multiple lines of hormone therapy and chemotherapy and other treatments. So I know that I'm a medical oncologist, and I wanted to focus on, in one slide, what are the therapies that we have at our disposal. We have a lot of different therapies that are appropriate for certain patients. It's impossible, to cover all these in one talk, and I really wanted to make sure that I was addressing many of the concerns that people in the community might have about prostate cancer without going into the minute details of how we treat the metastatic type of prostate cancer, which is frankly quite rare, thankfully quite rare. But there are many ways to treat metastatic prostate cancer. Those involve hormone suppression, where we block hormone production, testosterone production, or we have chemotherapy drugs like docetaxel or cabazitaxel. A lot of patients don't want to receive the chemotherapies. We also have a prostate cancer vaccine, which is called Provenge. We have a radioactive substance called radium-223, which targets the bone metastases. And then more recently, we have a new drug, a brand new approval by the FDA 3 months ago, called lutetium PSMA, and I have a slide about that because it is pretty exciting. So let's talk about PSMA, because this question always comes up whenever I talk at advocacy groups or patient groups. So PSMA is not the same as PSA. It stands for prostate-specific membrane antigen. And the membrane means that it's found on the cell surface membrane of the prostate cancer. And this is what the protein looks like. And this blue line here is the cancer cell membrane. So it's attached to the membrane. Some of it sticks out and some of it stays inside the cancer cell and on the membrane. And the reason that this is important is because PSA does not stay on the membrane. That's why it can be measured in the bloodstream. But PSMA stays on the membrane. It cannot be measured in the blood, but it can be used as a target to develop both scans to target prostate cancer and therapies to target prostate cancer. So let's talk about the scan and let's talk about the therapies. So the scan is called the PSMA PET scan. There are two PSMA PET scans that have become FDA approved. They were FDA approved last summer, August of 2021. And the two PSMA PET scans are called gallium PSMA, and the second one is called Pylarify. And this here on the left and on the right shows the same patient getting a conventional bone scan on the left, where you can see one single spot showing up in the pelvic bone. And on the right-hand side, the same patient, you can see with a PSMA PET scan, he's got a lot more cancer that was not seen on the bone scan. Only the one spot here was seen on the bone scan. And now you can see all these extra black dots. What does that mean? It means that the PSMA scan is much, much more sensitive and much, much more specific. So it can pick up prostate cancer that has spread to other organs that was not previously detectable by conventional scans. And then the other thing you can do is you can fuse a PSMA PET scan with a CT scan. That's called a PSMA PET CT. And if you do that, each of these areas that lights up in bright orange is the cancer. So this patient has a lot of bone metastases involving the spine and some metastases involving the pelvic bones and the prostate gland itself. And here you can see on the side view, the spine and the pelvis here, and there's a bunch of prostate cancer involving the spine in this case. And we have access to these PSMA PET scans here at the University of Minnesota. And this is one of the advantages of coming here to get your care, because you can get access to these PSMA PET scans, and they are FDA approved now and covered by virtually all insurance companies. And then the other exciting thing about PSMA is that we now have a therapy that targets cancers that make PSMA, and about 85% of prostate cancers do make PSMA. And the therapy has a long name and a short name. The long name is 177 lutetium PSMA-617, and the short name is Pluvicto. Pluvicto is a injectable radiotherapy particle, so it is a type of radiation, and it's a radiotherapy particle that binds to PSMA. So it's injected into the bloodstream, it circulates throughout the body, it latches on to the prostate cancer cell that makes PSMA, and then after it latches on, it gets sucked into the cell, and after it gets sucked into the cancer cell, it gives off a radiation wave, and the radiation wave kills the cancer cell. So again, this is exciting. This was FDA approved in March of 2022. And there's only two places in the state that have this treatment available, the Mayo Clinic and the University of Minnesota. So patients who have a positive PSMA scan might be eligible for Pluvicto therapy. Not every patient who has a positive PSMA scan is eligible for it, but if you're not sure, please make sure that you come and see one of the medical oncologists here, and we will discuss that with you and let you know if you're eligible or not. So this is my last slide. I've shared some of the bad news about prostate cancer, but also some of the good news. It is a very common cancer in men. Unfortunately, screening has been underutilized, although in recent years, the uptake of screening has begun to increase again. Hormone therapy does have a number of side effects, although at the same time, it is a very effective treatment for prostate cancer that has spread outside the prostate gland. The good news is, again, 80% of the time, if prostate cancer is detected early, it can be cured. Even in patients that cure is not possible, the death rate is very low and survival is long, in the order of 10 to 15 years. We now have two new technologies that target PSMA. Both of them are available here at the University of Minnesota. Both the PSMA PET scan, which is the imaging tool, and the PSMA Pluvicto, which is the therapy. And once again, I'd like to thank you and remind all of you that September is National Prostate Cancer Awareness Month. And with that, I'd like to thank you guys, and I will stop sharing my screen and open it up to questions. Thanks a lot.
Thank you so much, Dr. Antonarakis, for your very thorough and informative presentation. So we have time for a couple of questions, but in true fireside chat fashion, I have to get our fire going. So let me just share that quickly before we dive in. So we've had quite a few questions submitted already through the Q&A, so I can start with those. So back when you were talking about the statistics between the developing countries and the underdeveloped countries, so is the statistics of prevalence impacted by the level of screening? I mean, so this question specifically says that they would envision, questioner says they would envision that in more developed countries, the screening is more prevalent, which is why you're catching more cases.
Yes, so there are some caveats there. The two main caveats. One is the screening. So again, obviously, because many men with prostate cancer die with it, not of it, you may not know that you have it, so you might be actually falsely underrepresenting the incidence in cases where you're not screening. And the second is in countries where life expectancy, might be 50 or 60 years, those patients don't live long enough to get prostate cancer. So in parts of Africa, where median life expectancy is unfortunately 50 or 55, many of those patients might die of other things, infectious disease, heart disease. But yes, the prevalence of screening does artificially, quotes unquote, increase the prevalence.
All right, thank you. So just while we on that topic, what might contribute, do you think, to the higher rate of prostate cancer in France? Is it diet, etc.?
Well, I'm going to speculate. Dietary fats, lipids, and sugar are all risk factors. And in countries like France, there are diets, high in butter, high in cholesterol, high in, sweets, pastries. That might be one of the reasons. The other reason, of course, as we mentioned before, is, France is among the European countries with the highest screening rate. It's also a country where longevity is very high. It's one of the countries where, median life expectancy is 80 or 82. So people are living long enough, to get the diagnosis.
All right. Okay, so for symptoms, so are prostate cancer symptoms identical to the benign prostatic hyperplasia? I think that's what BPH stands for.
Yes. Often they are, because a prostate gland can be enlarged, either due to BPH or due to cancer, or sometimes both. The symptom of urinary obstruction, in other words, weak stream or blockage, that one is very nonspecific. Frequency, urgency, that can be very nonspecific. If you ever have bleeding in the urine or blood in your ejaculate, that usually does not occur with BPH. Also, a patient should not be losing weight with BPH. So if someone has, unintentional weight loss, and of course, unfortunately, if the cancer is bad enough to spread to the bones and the patient may have bone pain or those types of symptoms, you would experience a different type of symptom. But on the whole, yes, the symptoms of cancer can be very similar to those of BPH. But again, one lesson here is, if a patient ever sees blood in the urine or the semen, that should never be due to just BPH.
All right, thank you for that. So if you could answer this question quickly, I know you mentioned this, but what led to the decision against the PSA screening back in 2012?
Yeah, there were two things. One of them was that there was an American study and a European study trying to answer the question of whether PSA screening actually saves lives or not. There was no question that PSA screening detects cancer earlier, but the unanswered question was, does earlier detection translate into less deaths from prostate cancer? The American study showed that there was a reduced risk of death. The European study showed that there was not. And so because the jury was out, and actually the European study was a little bit larger than the American study, and there were more countries involved. Those two studies had differences in how often the PSA screening was done. So the European study was every 3 years, the US study was every 1 year. So there were differences. The second factor, however, was that the task force was focused on the potential harms that could be done to patients at the time of a biopsy. So the argument was, if you have a PSA, the PSA itself does not diagnose prostate cancer. It just tells you that you need to have a biopsy. And we do know that many biopsies will just show benign prostate, tissue, not cancerous. And every time you have a prostate biopsy, you have an increased risk of infection like prostatitis. You have an increased risk of bleeding. Of course, you have the discomfort and the pain of the procedure. So when the task force weighed the risk of a biopsy, given that most patients with a high PSA will still have a normal biopsy, not a cancerous biopsy, they said that the risks and benefits are outweighed by the risks because of the potential downside of the biopsy itself. So those are the two main reasons. But of course, all of that was sort of trumped when we saw that the death rates were going up in the 5 years after screening was recommended against.
Let's see here. Okay, so for our younger people and those under the age of 50, and particularly African American men, what can they do to reduce their risk of potentially developing prostate cancer?
Yeah, so first of all, if you are able and willing to undergo the PSA test once a year starting at age 50 and the rectal exam, please do so. The best way is to try to prevent overweight or obesity. Try to have a healthy weight, with a BMI, in the 20 to 25 range, but body mass index 20 to 25. Try to have a diet that is rich in plants and vegetables. It turns out that the green leafy vegetables and also the cruciferous vegetables, in other words, broccoli, Brussels sprouts, kale, asparagus, a lot of the stuff that might taste bitter and we may not want to put into our diets, those things are going to decrease the risk. Also, anything that contains antioxidants. So for example, fruits, especially berries. So blueberries, raspberries, pomegranates, green tea actually contains a lot of antioxidants. Don't drink the green tea that has sweetener or sugar added, but tea or green tea. And then nuts. Nuts have a high concentration of the omega-3 fatty acids, especially walnuts and almonds. So almonds, walnuts, and sometimes if you like almond milk or things like that. And then finally, healthy exercise, aerobic exercise, anything that gets your heart rate up, anything that causes you to, break out in a sweat, not necessarily like the muscle building exercises, but more like the cardiovascular exercises. And then finally, plenty of hydration, water, 6 glasses of water per day. Try to avoid drinking things that have sugar added, like pop, soft drinks. Coffee is fine, tea is fine, but try not to add sugar to your coffee, or if you do, don't add that much. And then sleep seems to be important. Try to get at least 7 hours of sleep per night. Try not to have sleep that is disturbed. Try to have 6 or 7 hours of continuous sleep.
This is great. Thank you so much, Dr. Antonarakis. So we'll wrap up here. I know we're over time, but just one key message you would like our audience today to take away from your talk.
Key message is, prostate cancer is curable if caught early. Please encourage all your family and friends and yourselves to do prostate cancer screening after discussing it with your doctor. And if you get diagnosed, it really is a good idea to come to a specialized center. It's a disease that is complicated. It can be treated right and it can be treated wrong. And places that don't have much experience, unfortunately, some mistakes are made, and those mistakes can be irreparable. Either you miss your chance of a cure, or you get a cure, but you get a terrible side effect from it. So, it's the one thing that I would recommend to people, go to a highly specialized center if you get diagnosed with prostate cancer. Unfortunately, in the state of Minnesota, the university and also the Mayo Clinic are great places to be at.
Wonderful. Thank you so much. So we are out of time. I wish we could have answered everyone's questions today. Dr. Antonarakis, thank you so much for just taking the time to join us today and help us raise awareness about prostate cancer this month. So you will all receive an email shortly after today's session with a link to complete a quick survey. We would appreciate if you could just take a few minutes to provide us your thoughts about today's session, because we use that information to plan our future programs. So after completing the survey, you will be entered to win a swag bag, which will include goodies from the Masonic Cancer Center. The $5 Amazon e-gift cards will be emailed out to all non-University of Minnesota affiliated staff, faculty, or staff in the next few days. And our next fireside chat will be next month in honor of Breast Cancer Awareness Month, and it's just going to be in a few short weeks here, so on Wednesday, October 5th. And we will be joined by Dr. Noel Hoven. So mark your calendars. And also, please make sure to follow the Masonic Cancer Center on all of our social media platforms to stay up to date on future announcements and events from the Office of Community Outreach and Engagement. Thank you again so much, everyone, for joining us today. Sorry for keeping you over time, but we hope to see you all soon. Have a great rest of your day. Thank you so much, Dr. Antonarakis. Take care.